Thanks, PlasmaGen, and thanks for kind introduction. Uh, it's a pleasure to discuss the role of IVIg in this COVID pandemic. I'll try to share my screen. Uh, we all doctors are praying hard to this how this pandemic goes away and how we handle this pandemic and also how we save life. So main idea is to save life is the most important thing which we want. So my slide is looking. You can see. Hello. Yes.
Yes, sir, we can clear. You
Okay.
can probably
Okay.
share
Okay.
full screen
Okay.
and it will
Okay.
be clear. Yes,
Yeah, it's a
thank you.
full scale. Yeah.
Okay.
So we all wanted how we can save life. Now it's a in a community spread and here and there in almost in every doctor's family and every family is being affected by this COVID second wave. So uh, previously, tocilizumab was being introduced and was studied, given as a like saving to tame the storm and because of scarcity of this drug, now focus is towards alternative things which can be given and which can be a safer option to the patient. With a lot of cases of secondary infections, mucor also we are seeing nowadays here and there in one hospital in Indore, there are 21 mucor cases admitted at this point of time. So we have to uh, deal with this pandemic. We have to deal with this COVID. We have to deal with this inflammatory response, hyperimmune response. But we also have to keep in mind the safety of the patients and the side effects of medication and all. So in that aspect, IVIg, I think so. It's a good molecule. IVI immunoglobulin, I am using it in rheumatological conditions for almost 15 years now, and especially in cases of crisis or in in cytokine storm in rheumatological conditions, we use this molecule nicely and almost 80% times we are successful in dealing patients with this storm. Also, I have used this molecule in cytokine storm triggered by other viral illness. This viral illness is very notorious to cause cytokine storm, or it causes after its 1 week of viremia phase. Then inflammatory phase begins, and this in this inflammatory phase, all viral infections can trigger cytokine immune response. And I have used this molecule previously in swine flu, in chikungunya, and dengue related cytokine storm. So that's why then we have started using it in COVID-19 cases of cytokine storm, and now we are quite successful in dealing these cases also. So that's why we are discussing here this molecule now. What is IVIg? Is a blood preparation isolated and concentrated from healthy donors, consisting of over 95% of IgG and trace amounts of Ig and IgM. Different doses of IVIg serve diverse medical indications, and clinical efficacy of IgG differs with dosage. For example, low moderate dosage it is given in primary immunodeficiencies, or in moderate doses or high doses it is being given in autoimmune diseases, other inflammatory conditions, dermatological, hematological conditions, in Kawasaki's and pediatric conditions and all. Uh, as a replacement therapy, it is being given as in immunodeficiencies. I told you primary and secondary, and as a immunomodulatory therapy in various specialists use neurologists use in neurological conditions like GBS, a very well-known condition, paraneoplastic syndromes, and chronic inflammatory demyelinating diseases, myasthenia gravis. In hematological diseases, you must have heard ITP here and there. In ITP cases, this is being used in autoimmune hemolytic anemia and other things. In dermatological conditions, everyone is used it in bullous pemphigoid, in the pemphigus vulgaris, TEN and all. In rheumatological conditions, we are used in dermatomyositis, lupus, vasculitis, vaginals, pan, and all. And ophthalmological conditions, they are used in autoimmune uveitis and all other. So all inflammatory conditions, autoimmune conditions, this can be used. So what is the science behind it in using IVIg? Why it is being, how it acts? Uh, underlying molecular mechanisms of IVIg are conferred by IgG. and its two functional domains. One is Fab, means
Dr. Malviya, sir.
disease. Yes.
Sorry, sir, to interrupt you. The audience cannot see your slides, sir.
Oh, you cannot see my
Yes, and you can do F5, sir. It'll make it as full screen.
slides. Just hold on. Now, now can you
Yes,
see?
sir. Yes, sir. It should be coming up right now.
Can audience see now? Please confirm.
Anyone from the audience?
We're able to
Yes,
see
sir,
a slide.
visible.
Okay, sir. So you can just make
Okay.
it full screen, sir.
Yes, full screen. Full
F5.
screen.
Okay.
Okay.
So
So
we can, sir.
what? So 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 uh, uh, so what is the molecular mechanisms? Mainly mechanism of IVIg therapy is inferred by IgG and its two functional domains. Fab. This is antigen. In second figure, you can see structure of IgG. F antigen binding domains, and other is Fc fragment. In this Fc fragment, it is mainly it's a binding receptor binding for this complement binding and receptor binding area. This Fc fragment, and FAB is dimeric antigen binding fragment. So here this acts, and what happens with these viral infections? This causes a lot of toxin release, lot of antigens, lot of so this with this Fab antigen binding domains, this IgG causes neutralization of pathogenic antigens, including micrograms of toxins, uh, neutralizations including cytokines and chemokines. Then it increases the apoptosis related molecules. I'm sorry, this figure is like slightly busy, but I'll explain in a couple of minutes. So what happens in Fc mediated mechanisms? It causes saturation and limiting access of immune complexes to activating Fc receptor domain. Then it causes saturation of neonatal Fc receptors and enhanced pathogenic clearing antibodies, and upregulation of inhibitory Fc receptor inhibitory binding proteins, and which it increases the activation threshold. Then squelching of complement fragments and inhibition of complement activation system. It means it increases phagocytosis, it increases scavenging complement fragments, it increases anti anti-inflammatory cytokines, it reduces pro-inflammatory cytokines, it neutralizes toxins in the Fab in the figure 1a. You can see here it neutralizes toxins, cytokines, and it increases the autoantibodies. Secondly, in Fc mediated in third figure B, you can see it saturate neonatal Fc receptors clearance of autoantibodies. This is increased. Complement system activation is reduced. Innate activation, immunity activation is reduced, and pro-inflammatory cytokines are being reduced. You can see here in figure C and figure D. Figure C is innate immunity, and figure D is adaptive immunity. So, what happens in figure C? You can see macrophage activation is reduced. Inhibitory Fc binding proteins, which causes inhibition of inflammation, are increased, and all these things. NK cells activation is down regulated. NK cell mediated cytotoxicity is down regulated. So all pro-inflammatory things, in nutshell, all pro-inflammatory cells are down, things are down regulated, and all pro-inflammatory cytokines are down-regulated, anti-inflammatory cytokines are up-regulated. So this IVIg causes, in nutshell, inhibition of immune complex formation and reduction of pro-inflammatory cytokines, and many more things. So, what immunopathological hypothesis of viral phenomena? What this viral causes? This active immune response is essential for pathogen elimination in acute inflammatory, any respiratory viral infection or any viral infections. What happens? This viral triggers inflammatory things, and these excessive defense reactions may create havoc to the healthy tissues and cells. So, viral infection just gives a trigger, but this hyperimmune response make the cells, healthy cells, dead, and but this is the problem with this cytokine storm. So complications is mortality and excessive production of pro-inflammatory cytokines, and then multiple organ dysfunctions. Immunopathogens of SARS-CoV has not been fully described, but you must have heard hyperimmune response, thrombosis, and there is a all in lung tissues you will find inflammatory cells and intravascular thrombosis. So IVIg reduces both. It reduces hyperinflammatory response, and this in secondary because of reduction of hyperinflammatory response, pro-cognitive studies also being reduced actually. So cytokine storm is a full form of systemic inflammatory response common to all viral infections, as I was telling you, and this presence we have seen in whole year, 1 year. We are seeing these cases, and this viruses causes sprawling network which involves endothelial cells, mononuclear macrophages, dendritic cells, NK cells, lymphocytes. This contributes to pathologic clearance and immune protection. But uncontrolled positive feedback, which is happening in this viral infection, uncontrolled positive feedback, this causes hyperinflammation and causes excessive damage to all these tissues. So IVIg may help in reducing this uncontrolled hyperinflammation and then thereby saving these cells and tissues. There is one interesting fact going on. You can see, you must have heard about ADE, antibody dependent enhancement phenomena and role of IVIg. What is happening? Humoral immune response to invading pathogens may produce neutralizing antibodies, and this is crucial in host adaptive immune response. But paradoxically, what happens in these viral infections? These antibodies may paradoxically provide an attractive means they catch, they smoothen the entry of virus to the cells, and they thereby they may enhance viral replication in some tissues. So this is the paradoxical things going on with this viral phenomenon that is called ADE. This this hello this unique phenomena that is pre-existing, that these poor neutralizing antibodies facilitate viral access to the Fc receptors and lead to enhanced infection of immunopathology. So this is called antibody dependent enhancement. So this antibody dependent enhancement happens very well known phenomena in WNV virus, encephalitis virus, but this is also happening in this COVID pandemic. So ADE means antibody dependent enhancement happens in this COVID-19, and IVIg may also down regulate this ADE. So it's a complex thing, but I hope with minimal these two things, hyperimmune response and antibody dependent enhancement, these two factors, if we control by IVIg, then I think so cytokine storm can be tackled up. So there is a study, if we they was seen whether IVIg, if started within 48 hours of of admission, and after 48 hours of admission, then they have seen very good result. And this already I have discussed about. This is mainly immune phenomena going on with this COVID pandemic, and in lungs there is hyperimmune response. So this can be seen, and this high dose of immunoglobulin for the treatment of COVID-19, what they have seen, most of the infected individuals with COVID-19 experience mild symptoms. We don't need anything for them. Some rapidly progressive severe respiratory failure may need this molecule. So optimal treatment strategy for COVID-19 still is not known, but early initiation of IVIg and heparin may help in controlling severe critical pandemic. So this is the phenomena which they have thought, and the study was designed. It is a retrospective study, observed the relationship between prognosis of patients. The retrospective study observed the relationship between prognosis of patients severely and critically in COVID-19 pneumonia and adjoined IVIg therapy, and explored whether IVIg could improve clinical symptoms, lab examination, and prognosis of these patients. 58 cases of severely or critically ill patients due to COVID-19 diagnosed in ICU, and inclusion criteria of all diagnosed cases and confirmed cases of RT-PCR. So you can see this selection of patient is important, and this selection of patient we can select in our area also. In severe exclusion criteria where severe short of breath, more than 30 respiratory rate, oxygen saturation at rest less than 93, ABG, PA pressure upon oxygen obstruction is less than 300. Pulmonary imaging shows obvious lesions more than 50% within 24 to 40 hours. This was the exclusion criteria. And critical criteria: respiratory failure, requiring mechanical ventilation, and complication of organ failure. So primary outcome was 28-day mortality, and secondary is 14-day mortality, hospital stay, length of stay, and all, requiring mechanical ventilation and all. So treatment plan was all patients receive oxygen, antiviral therapy, initiation of antibiotic and heparin. And when absolute lymphocyte count falls below 0.5 into 0.9, then they receive IVIg at 20 gram per day. So patients in critical conditions may receive steroids dosage 1 to 2 mg per kg 5 to 7 days, but IVIg was given to lymphopenic stage. Significant difference in 28-day mortality between two groups, like you can say 23% and 57%. And length of stay in hospital was less than 48 hours was significantly shorter than in the more than 48 hours group. So you can see in this diagram, more than 48 hours, length of stay is more than 20, and less than 48 hours it is almost less than 15. So length of stay is being reduced, mortality is being reduced as per their diagram. So length of stay in ICU less than 48 hour group was significantly shorter than the 48 hour, more than 48 hour group. So early use of IVIg reduces the length of stay in ICU and reduces the mortality. So so there is a difference between late usage and early usage in this study. So this study favors early usage than late usage. Proportion of patients requires mechanical ventilation in less than 48 hours group was significantly lower than in more than 48 hours group, and 6 versus 32, and 28 days survival time of was also significantly longer in more than in this group. So you can see here 28 days survival in diagram A and diagram B. You can see percentage of survival. This dotted line is more than 24 hours, and flat line, full line, bold line is more than 24 hours. So you can see percentage survival. Dotted line is low in 28 days, and even in 48 days, 14 days, this is again the same. And so early usage increases chance of survival. Again this. So outcome, it reduces the use of mechanical ventilation, promote early recovery, shorten the hospital length of stay, improve the effective treatment of patients to achieve significant clinical efficacy. So this is another study, use of intravenous IVIg for treatment of severe COVID-19. This was the randomized placebo control. That was earlier study was the retrospective study, and this is the randomized placebo controlled double-blind trial. And so what was the method in this? One group used IVIg 4 vials daily for 3 days. In this group, they have used 4 vials daily for 3 days, while others used placebo. So adult patient, involvement of CT less than 30% of both lungs, oxygen saturation of less than 90. So and lack of adequate response to initial treatment. So total study subject 30 patients received IVIg and 29 patients received placebo. So in hospital mortality was significantly lower in IVIg group compared to control group. You can see here 20% and 48%. So this analysis demonstrated that this is significant impact in reduction in mortality. So conclusion is administration of IVIg in patients with severe COVID-19 who did not respond to initial treatment could improve clinical outcomes, but high price is the key challenge. So we suggest that it can be considered in patients with more than 30% lung involvement also, whom their dyspnea does not improve with standard treatment, and persistent hypoxemia, oxygen saturation less than 90. And so these are the suggestions which this author has given. Even in pediatric age group, in children are very notorious to have hyperinflammatory response. And any viral illness triggers this hyperinflammatory response in children. In compared to adults, children's pediatricians see more inflammatory response in children, and they use IVIg like anything in pediatric age groups. So I'll not discuss in detail about these pediatric things. What one has to understand, what is the profile they see hyperinflammatory conditions like persistent fever, persistent abdominal symptoms, hypotension, shock, laboratory profile lymphopenia, marked inflammatory markers like high ESR, high CRP, high ferritin, and other, because children they do see myocarditis, and also so they do all these things, electrocardiography and pericarditis, these markers also. So I'll not discuss in detail about this study, but findings are IVIg helps in this pediatric population also. Even in American College of Rheumatology guideline, you can see down the line, everywhere they have recommended IVIg, remdesivir, IVIg, and aspirin and IVIg. In every phase, they have recommended IVIg. This is a busy slide. I'll not discuss in detail about this slide, but in pediatric group also they have recommended IVIg. Thank you for patient listening. Sorry for these slides. I cannot share these slides properly because of technical issues. But I hope I have conveyed my message regarding IVIg and in this study mechanism of action and timing of usage and outcome related to IVIg. And I think so. Next speakers, Dr. Ravi and Dr. Tanay, may share their practical experience in these COVID-19 cases. And thanks a lot. And then after that, I will discuss.